My name is Megha Ramaswamy. I'm a professor of population health at the University of Kansas School of Medicine. I will talk to you today about cancer screening among prisoners. So my expertise is in cervical cancer prevention and women's health. I'm trained as a social scientist. I implement public health interventions, evaluate them, and disseminate information about what works. So I hope to both extrapolate lessons from my work on cervical cancer to screening more generally for cancer in prison settings, but to also talk about prevention and public health as it relates to cancer screening. So the top cancers for people in prison are liver, cervix, and lung. In a study of Ontario prisons, women in particular, and I work with women, were 10 times as likely to have liver cancer, 5 times as likely to have cervical cancer, and 3 times as likely to have lung cancer. And so those are really the 3 cancers I want to focus on for this presentation. So what do we know about cervical cancer? We know that the rates of cancer with women who are incarcerated are high, much higher than women in the community. And we also know that the reported rates of screening, so for example, pap smear exams, are also pretty high. In some studies, they're as high as 75 to 80% up-to-date pap screening, which is pretty good and pretty similar to the general population. We've also found that abnormal pap smear follow-up, which is what you need to do to prevent cancer, is low at about 50%, so that women have challenges once they do get a pap screening for following up. So there's a story here about continuity of care and maybe getting lost to follow-up. There's also some question, though, about whether women overestimate cancer screening. Are they misunderstanding, for example, a pap exam with a pelvic exam? And so what does that mean for getting up-to-date information about women's cancer screening rates? I'll also say, and it's probably been covered in another presentation, that there's lots of risk for cancer among people who find themselves in prisons. So 80% of the women we work with are tobacco users, lots of smoking. The women we work with, as well as the men, have long trauma histories, sexual health risk histories. And at least as far as the United States, many people find difficulty accessing health care. So in the United States, as you probably know, we do not have guaranteed access to health care. And so women, when it comes to cancer screening in many states, have to cobble together resources to follow up, and if they do have a cancer diagnosis, to ultimately get treatment. So I want to talk to you about cancer screening in terms of 3 levels of prevention: primary, secondary, and tertiary. What I found from my research as it relates to primary prevention is the need to really build cancer health literacy. So I've spent the last 10 years designing cancer health literacy interventions as a way to build women's health literacy and then ultimately get them into screening, and those interventions have been effective. So what does cancer health literacy mean? That means knowledge about cancers. It means beliefs about screening. What are your beliefs about screening when you're asymptomatic, for example? It means that you have self-efficacy for screening. So we work with women who are transitioning out of incarceration. And how can a woman prioritize cancer screening, for example, for cervical cancer, given other challenges with homelessness, drug use, mental health problems? And so what cancer health literacy means to us is helping people build literacy around what they know about a disease, their beliefs about the importance of screening, addressing their fears about screening, and then their self-efficacy for that screening. The second area of primary prevention that I'd really like to focus on is vaccination. So with the top cancers that affect people who are in prison, there is a huge infectious disease connection. So HPV, hepatitis B, and hepatitis C account for pretty much most cases of cervical cancer and liver cancer. And there are really huge missed opportunities in prevention when it comes to vaccination. So we've studied HPV vaccination with men and women, and when the US had approved HPV vaccination for people 26 and under, we found that only 35% of age-eligible women were vaccinated, and only 8% of age-eligible men were vaccinated. When it comes to hepatitis B vaccination, only 5 states in the United States have prisons that routinely vaccinate for hepatitis B. And with both of these infectious diseases and vaccination, we really just don't have rigorous information in the US about the rates of vaccination across the board. When it comes to hepatitis B vaccine, in some populations, the vaccine rates are as low as 4%. But when you intervene, and I have found this in my research with HPV vaccine, and others have found it with hepatitis B vaccine, that not only are people in prison interested in taking vaccine, but that they also will complete a series. So one study of hepatitis B vaccine, I believe in Texas, showed that 95% of prisoners, or I think maybe 96% of prisoners, completed their doses for a hepatitis B vaccine. And jails in the US are short-term facilities where people are incarcerated for much shorter stays, usually under a year. And in those short-term facilities, about 54% of people who were offered hepatitis B vaccine completed their vaccination series. So there is promise here for vaccination. The third area of primary prevention I'd like to address is substance use treatment. So huge correlates of cancer risk, especially for lung cancer, are smoking, alcohol use, and as I've said, there are high rates of smoking in prisoner populations, and there may be potentially missed opportunities for smoking cessation treatment once people become incarcerated. We've also found that 50% of the women we work with have lifetime alcohol use problems. So not just casual alcohol use, but problems with alcohol that get in the way of everyday life and indicate the need for alcohol treatment. And we just simply don't know, nor do we have available routine access to smoking cessation and alcohol treatment. And those are missed opportunities for primary prevention. When it comes to secondary prevention, and this is really about screening for cancer, we know that people who are incarcerated are at high risk for hepatitis B and hepatitis C. Those illnesses, particularly hepatitis C, have a high cost of treatment. And in the US, there's really a difficulty in figuring out who's going to pay. And so often prisons in the US don't do routine screening because we don't have really a good answer to who is going to pick up the tab when you find out that someone has an illness that you now have to pay for. And as a result, we don't do routine cancer screening for liver cancer because liver cancer screening is predicated on the presence of the infectious disease. And so if we don't screen, people don't get treatment. And we know that people who have a incarceration history end up showing up a lot later to oncologists with much more advanced disease, and this is potentially one of the reasons because we don't do routine screening. Similarly with cervical cancer, if we know women fall through the cracks on our normal PAP follow-up and high-risk HPV follow-up, and by the way, we have no information that I can find about routine HPV typing in prisons in the US, then how can we prevent disease progression if we simply, don't know? Routine early screening is critical, but there's so little knowledge in the field about the routinization of lung cancer screening, even though the recommendations for lung cancer screening are clear. We know that there are low rates of hepatitis C screening. One study showed only 16% of prisons in the US do this kind of screening, and we don't have routine information about cervical cancer and mammography screening in the US. This suggests that from a secondary prevention perspective, that we need robust data collection to understand baseline information about missed screening opportunities. That is the first step. And then the second step, of course, is to figure out, well, then how do you routinize screening for these cancers and the infectious diseases that underlie them? The last area I'll talk about is tertiary prevention. So there's plenty of evidence to show that cancer is a primary cause of death among older prisoners, and this is a missed opportunity. These deaths are potentially preventable. We know also that when people finally show up to oncology for treatment, people with incarceration histories have a disease that is much more advanced and complex, and so coordination of treatment services is a challenge. So my final recommendations are primary prevention solutions around helping to build people's cancer literacy, offering vaccination for the infectious diseases that underlie cancer, and substance abuse treatment. Secondary prevention solutions include a robust research agenda on routine age-appropriate screening, and then as a next step, rolling out evidence-based screening protocols in criminal legal system facilities. In the US, of course, there is a worry about who is going to pay the bill for expensive treatments, and that is something we have to sort out from a policy perspective. At the tertiary level, we have to work with oncologists to determine best practices at the facility level for coordination of care. It's so common to see advanced cancer patients in oncology service, patients who come from prisons, and that could be preventable. Thank you so much.